Welcome everybody. My name is Dr. Fred Bloem. I'm here to present to you a webinar on the topic of testosterone replacement therapy for men. We do have some women here on the webinar tonight, and that's great. Now, some of the information will apply to women as well, but this is mostly geared towards treatment in men. I have with me Alan Chiet from Knowles Apothecary. We've known each other for more than 10 years, I believe, right, Alan? And so we've had a very nice working relationship. He's right here in Kensington, about 20 minutes from my office, and they have a very, very nice pharmacy and provide excellent service. So just a little bit about myself. I'm from the Netherlands. I born and raised there, went to medical school there, then came to the United States in 1990, did a year of internal medicine, followed by a year of anesthesiology. Then I did 2 more years of family medicine, practiced as a traditional allopathic family doctor for a number of years. But at some point, I just discovered that I didn't really enjoy what I was doing. I recognized that I was just prescribing drugs to treat certain symptoms, and that simply wasn't satisfying to me. So I was looking for a way to get to the root cause of my patients' problems. And one of the first thoughts that came to mind was that I had to help my patients lose weight. I attended some conferences having to do with weight loss. I thought that if I only could help my patients lose weight, their blood pressure would improve, their diabetes would improve, their joint aches would improve. I thought initially that that's all that I needed to do. But surely enough, I found that was far from the truth. And I discovered that there was a lot more to helping patients get well in the safest possible way. So I learned about bioidentical hormone replacement therapy more than 10 years ago. I've attended numerous classes and conferences. I've learned about nutritional therapies, both oral nutrition as well as intravenous nutrition, various detoxification protocols. I put maggot debridement therapy on there. I don't do it a lot, but from time to time I get some inquiries from patients who have difficult wounds that just won't heal, and maggots do a very nice job cleaning that up. I've learned a variety of biooxidative therapies, including ozone, ultraviolet light therapies. I do injection techniques like prolozone for arthritic joints, neural therapy, autonomic response testing as taught by Dr. Dietrich Klinghardt, applied psychoneurobiology, also taught through his courses. And this year I'm learning some new things, which include peptide therapies and supportive oligonucleotide technique, which can be helpful for patients with cancer and chronic infections. I'd like to turn the time over to Alan from Knowles Apothecary. Would you just take a few minutes to introduce yourself?
Sure. Hi, everybody. My name is Alan Chiet. I've been a pharmacist for almost 30 years. I went to school in Boston. I'm from Boston. Went to Northeastern University and graduated and worked for independent pharmacies. I worked in hospital pharmacy and in chains. I've been a compounding pharmacist for more than 20 years, and our store here in Kensington is a sort of traditional alternative. So we have vitamins, supplements, homeopathy. We have a clinical herbalist, a nutritional advisor, and regular straight up pharmacy, pills off the shelf kind of thing. But we specialize in compounding. So what compounding is, for people that hasn't touched you in any way, is basically we do like customized medications for patients, and we fill the needs where some patients have certain allergies or need special dosing or a particular dosing form, and we're able to, with a doctor's prescription, make these medications up. With Dr. Bloem, we do a lot of HRT, hormone replacement therapies. We also do a lot of veterinary compounding. So people come here and, we have the mom and dad getting HRT replacement, and we also take care of the pet as well. So we do a lot of different things. I've worked with NIH, we work with the aquarium, we work with the National Zoo, we work with a lot of local practitioners, and again, we're also a PCAB accredited pharmacy, so we're an accredited compounding pharmacy. And what that also means is any pharmacy can compound, but if you want to sort of set yourself aside from the usual corner pharmacy, we go through additional testing and have additional inspections to make sure that we comply 100% with USP guidelines that make sure that patients get the most accurate product that is consistent at all times. And, that's sort of our background here at Knowles. Again, we've worked with Dr. Bloem for over 10 years. His patients have always been very, very happy with him, and can't say can't say enough, great things. So we've seen a lot of patients come in, not feeling great, not doing very well for some period of time. And, they get onto a regimen with Dr. Bloem, and, it's been a really great interaction with us. And, we kind of in compounding call it the triad. So it's always the patient, the physician, and the pharmacist. And, whether you choose to, use a pharmacy, use my pharmacy or another compounding pharmacy that's up there, you always want to make sure you have a good relationship with the doctor and with the patient, and that, we all listen to each other. And unlike some of the chain stores, I mean, our patients here really get a one-on-one interaction. We get a lot of phone calls, we answer a lot of questions, things that we can't come up with or find the right answer to. We always call the doctor and get the doctor involved, and make sure that you get the best outcome possible. So I guess I'll let Dr. Bloem go back and talk about testosterone a little bit, and we can talk about some of the commercially available product and then some of the compounded.
Yeah, thanks a lot, Alan. So certainly this is a very big topic, and I'll try to keep it as simple as possible. Some of the information is going to be a little bit technical, but there's going to be an opportunity to ask questions, and there's some things that Alan knows that I don't know, and vice versa. So we have a very, very good working relationship. So let's start with some facts about andropause. This is, of course, a word for male menopause. It's estimated that at least 20% of males over the age of 50 have low testosterone. It's common in men with other comorbidities like diabetes, hypertension, sleep apnea, and other chronic diseases. It's linked to early heart disease, a decline in cognitive function, and it's often underdiagnosed. And what I found is that doctors that come to me, patients who come to me often have they have their cholesterol checked, they have their chemistries checked, they have their thyroid checked, but almost never do they have their testosterone levels checked. So it's very often overlooked. So testosterone is a very important hormone, especially for men, but certainly also for women, but more so in men. So it's very important for the bones, for the brain, for the heart, and relationships. And that's of course as it relates to sexual function. So men make far larger amounts than women, and certainly when we prescribe compounded testosterone, the concentration of the male compound is 10 times higher than the female compound. So it's estimated that men between the ages of 30 and 70 will lose 1 to 3% production of testosterone per year. And for women between the ages of 20 and 40, it's estimated to be up to 50% loss per year. Now, this looks a little bit overwhelming, but I'll just break it down. So certainly there's a lot of different hormones. There's the pineal gland there at the top, which makes melatonin, very important hormone, but we won't discuss it today. Then there's the hypothalamus, which is a part of the brain that's very important, not just for hormone function, but also for other functions. But the important thing for this webinar is that it creates releasing and inhibiting hormones. For example, here we have gonadotropin releasing hormone, and there's thyrotropin releasing hormone, and so on and so forth. And what these hormones do, they stimulate the pituitary gland. And the pituitary gland has two parts. There's an anterior part, the adenohypophysis, and there's a posterior part, which is the neurohypophysis. So there's, FSH, follicle stimulating hormone, luteinizing hormone, thyroid stimulating hormone, and others here. There's growth hormone here. There's antidiuretic hormone. There's oxytocin. Now today we'll focus on this part, the left part of this slide. And for men, the luteinizing hormone is especially important. So these hormones stimulate the ovaries in women and the testicles in men. They create testosterone, but also estradiol. And they're also important for spermatogenesis. So let's go to the basics. What are hormones? Essentially, they are messenger chemicals. So they are a chemical substance formed in one organ or part of the body by a hormone gland and then carried through the blood circulation to another organ. Every organ, tissue, cell has receptors for multiple hormones. So hormones can alter the functional activity of a cell. the tissue and organ, the structure. So they're very, very important. Okay, let's go to the next slide. So here's an overview of steroid hormone metabolism. So not all hormones are steroid hormones. For example, thyroid hormones are not steroid hormones. But what steroid hormones have in common is that they're all derived from cholesterol, and cholesterol is converted to pregnenolone. So here on the left side, we see the gonadal steroids or the sex steroids. Then pregnenolone, progesterone. Progesterone can be converted into 11-deoxycorticosterone, which is one of the glucocorticoids. And then on the right, we see the mineral corticoids, which include corticosterone and aldosterone. One of the very well-known glucocorticoids is cortisol, of course, also known as hydrocortisone. Let's go to the next slide. So here, just zooming in on the gonadal steroids, so we see that we have pregnenolone, there's progesterone, there's DHEA, sulfate there on the left. There's testosterone here, and testosterone can be converted into dihydrotestosterone, or it can be converted to estradiol. And that's actually important to know, and we'll see that later on. So there's different kinds of receptors for these steroid hormones. So here we see the mechanism of class 1 nuclear receptor action. And what we see here is that a hormone enters the cell and then connects to a receptor in the cytosol, outside of the nucleus of the cell. And then a cascade of reactions will take place. Something inside the cell will get activated in the nuclear DNA. Messenger RNA will be formed, and the messenger RNA will then produce some proteins, and all of this will result in a change in cell function. Here's a very similar slide. Now here we see a hormone going directly into the nucleus, again affecting the DNA, and again a cascade of reactions take place. A messenger RNA is formed, and again a protein is formed, and the cell function is changed. So hormones are very important. They regulate the activities of entire organs, growth and development, reproduction, sexual development and characteristics, the use and storage of energy, levels of fluid, salt and sugar. Now this is an important distinction to make. When I prescribe hormone therapy to my patients, I always prescribe bioidentical hormones. What this means is that these are hormones that are identical to the hormones that the human body makes. And for that reason, they form a perfect fit with the human body's hormone receptors. Now, sometimes people say, I don't want to have anything to do with synthetic hormones, but synthetic is not necessarily bad. And most of the bioidentical hormones that we use and that are compounded are actually synthetic. So they're plant-derived, and plant, of course, have hormones, phytohormones that are similar enough to human hormones that they can be modified and become bioidentical human hormones. So the non-bioidentical hormones are not naturally found in the human body, and the effects are often opposite and not life-sustaining compared to the bioidentical hormones. So they include all oral contraceptives, drugs like Premarin, so-called progestins, and most injectables. So these are some examples of non-bioidentical androgens. So that's a very, very long list. Of course, some of these are abused by athletes. And so here is the difference between bioidentical testosterone on the left and non-bioidentical methendienone on the right. So at first glance, they look pretty similar, but you see that there are some difference here in this cyclical structure and right here as well. And these small differences are very important. And this is commercially available under the brand name Dianabol. Now here we see two other molecules, again, natural testosterone and testosterone cypionate. Now they look very different. Now this is actually something that I do prescribe to my patients. This is an injectable form of testosterone. This is a testosterone esters. The patient injects this himself in the muscle, and in the body, this part will be released from the rest of the molecule. So bioidentical testosterone will be slowly released into the patient's circulation. So now let's talk about deficiency symptoms and potential causes and contributing factors. And the big question, of course, is do we age because we lose our hormones, or do we lose our hormones because we age? I think it's a little bit of both. Of course, when we talk about hormone imbalances, the levels could be too high. That's typically not a problem that I deal with in my practice, but most commonly the hormone levels are too low. And of course, the problem could be at the level of the hormone gland itself, at the level of the pituitary gland, or the level of the hypothalamus. We may also have problems with receptors, either reduced numbers of receptors or reduced responsiveness of the receptors, and there may be a loss of rhythmicity. Here are various factors that may affect hormone balance. Andropause, as we age, naturally the organs decline in function. Lifestyle factors such as sleep, diet may affect hormone balance. Nutritional deficiencies, iatrogenic, if a woman takes oral contraceptives, of course that disrupts her hormone balance. Other drugs may do the same. Trauma, physical or emotional, may have an effect on hormone balance. Endocrine disruptors, toxins like heavy metals, genetically modified food could potentially affect hormone balance. Food additives, electromagnetic fields like smartphones that you put in your pocket, back pocket or front pocket, Wi-Fi, 5G, all of that may have an effect on hormone balance. Now, xenoestrogens is a term that refers to certain chemicals that may be injected into meats to enhance growth of animals, certain pesticides, certain chemicals in plastics. There's contamination of our water supply with pharmaceuticals or contraceptives and so on. All of that may have an effect on our hormone balance as well. So there's a lot of different testosterone deficiency symptoms. The skin has receptors for testosterone. So as the skin ages, we start to look older. Muscle tissue has testosterone receptors, so we find that there's increase in muscle mass and strength, difficulty building muscle when you're working out. The intestinal tract has smooth muscle, and if there's a deficiency of testosterone, the peristalsis may be slowed down as well. Fatigue that worsens with physical activity is typical for testosterone deficiency. The brain has testosterone receptors, so that explains why sometimes patients have trouble sleeping. Just like women may experience hot flashes, men may experience hot flashes and sweating spells as well. Prostate has testosterone receptors. Low libido, loss of libido, erectile dysfunction are well-known deficiency symptoms. Again, because the brain has testosterone receptors, we find that older men often experience anxiety and depression as their testosterone levels drop. There's often reduced self-confidence, poor memory, increased fat accumulation, changes in hair growth. Eyes may become drier. There may be more tension and irritability, easy bruising, joint pains, and muscle pains. Now, DHEA deficiency symptoms are very similar to testosterone deficiency symptoms. Some of the symptoms that are more specific to DHEA deficiency include low resistance to noise and stress, loss of axillary hair and pubic hair, loss of fat in the pubic area. So all of these symptoms can be reversed when we optimize testosterone levels with natural testosterone replacement. And I've seen this over and over and over again. Patients that come to my office in pretty bad shape, but once they start on testosterone replacement therapy, they find they have increased energy, vitality, and zest for life. Just an overall improved sense of well-being, relief of depression and anxiety, improved mental clarity, memory, and focus. And it's estimated that men with low testosterone are 3 times more likely to develop Alzheimer's disease. Testosterone is believed to help protect the prostate, cardiovascular function, breast health in women, increased bone and muscle strength, reduced body fat, of course, enhanced libido and performance, and lower insulin resistance. When patients come to me, they prepare by preparing a medical history for me, and that provides the most important information for me. Just all of those deficiency symptoms, I can tell from the medical history whether or not a patient is likely to have testosterone deficiency or not. Learning about their diet, about their medications, toxins exposure, and all of that is important. Physical examination is important as well, but most of the information I do get from the medical history. And sometimes patients do come with pertinent laboratory test results, and of course that would be helpful, but very often I will need to order those myself. The types of tests that would be of interest include total and free testosterone, and the difference is that some of the testosterone is bound to sex hormone binding globulin, so that includes the total testosterone and the free testosterone, but a portion of the testosterone is freely circulating in the body and available for the body to use. We want to check DHEA sulfate, sex hormone binding globulin, estradiol. Estradiol is also important for follow-up. So if patients are taking too much testosterone, it's possible that the estradiol levels rise, and patients may develop side effects like gynecomastia, which is unwanted breast development. When the patient is over the age of 50, we'll check the PSA, prostate-specific specific antigen. We may want to check hematocrit, thyroid hormone levels, cortisols, and other tests as indicated. Now here's just a simple example. So a patient came to me having been feeling horrible for the past 8 to 10 years, loss of libido, erectile dysfunction, insomnia, fatigue, memory problems, sleep apnea, general joint stiffness and morning joint stiffness. And he actually did have testosterone level checked before he came to see me, and it was 284. And when you look at the reference interval, it's 264 to 916. And this is from LabCorp. Now, a lot of doctors will look at this and say, well, it's normal. But when you consider that the patient has been feeling bad for about 10 years, this is surely not normal. And the reference intervals are really not that helpful when you understand that the reference interval does not represent the optimal range. So young men tend to have a total testosterone level that's 900, at least 900 or above. When your hormone levels drop to 600, 500, that may already result in certain symptoms. And many of my patients that come to me with complaints have total testosterone levels in that range. So there's a number of different treatment options. So for my patients, I've used primarily transdermal creams and injectable testosterone cypionate. There's also commercially available transdermal gels, which I have not used much in my practice. Alan will explain a little bit about that. There's troches, there's pellets. I've actually taken classes on how to do pellet therapy, but I've not had any demand from my patients to have that done. So I've not done that in my practice. Now the Wiley Protocol is an interesting protocol that I learned about more than 10 years ago. One of my patients brought this to my attention. Teresa Wiley developed this protocol. She's not a health professional, but she's very, very smart, very, innovative in developing this protocol. She was featured in Suzanne Somers' book, Ageless, and published her own book entitled Sex, Lies, and Menopause in 2003. And in that book, she described the rhythmic dosing of bioidentical hormones for women. And she explained that the rhythmic dosing protocol should be synchronized with the lunar cycle or a woman's personal cycle if she still has her own personal rhythm. And so this is a bioidentical biomimetic because of the rhythmic dosing hormone replacement therapy protocol. So initially, there was only a protocol for women, but within a few years, she developed a protocol for men. And the protocol for men is based on 4-day sun cycles of magnetic fields. We have the patients use both testosterone and DHEA. And the DHEA cream is applied in the morning when the androgens normally peak. What happens is that the DHEA provokes an androgen receptor and lowers estrogen reception. And then the dosage is increased every 4 days to allow DHEA to create more receptors for testosterone. So here we see the dosing protocol for testosterone. And we see here that the numbers here are lines. It's essentially 0.1 ml on a 3 ml syringe. And the concentration is 10 milligram per 0.1 ml or 100 milligram per ml. When we start here with a morning dose of 2, so that's essentially 20 milligrams. And it goes up to, here it's 11, so that's 110 milligrams. That's the rhythmic testosterone dosing. So the testosterone is applied in the bend of the leg and the inner thigh, not on the scrotum. And we have the patient use it on one side and then alternate sides each week. Now here's the DHA rhythmic dosing protocol. And this is only applied once daily in the morning. And each line or 0.1 ml of DHA is 10 milligrams. And we have the patients apply the DHA in the lower back. With men, we have them follow the lunar calendar if they don't have a sex partner. If they do have a sex partner and she is following the lunar cycle or the personal cycle, we have them follow the woman's cycle, the woman's calendar, whether it's lunar or personal. And if they have a female partner who's not on the Wiley protocol, they would just cycle with the lunar calendar. And so this is how these hormones come packaged in color-coded bags and syringes. And so there's calendars like this one. This is the June calendar. We'll have a closer look at that. So what we see here in blue, those are the lunar days. And so, for example, June 5th is day 12, and it's day 12 because June 5th was full moon. So when it's full moon, that's always day 12. And then here in the calendar, we see the testosterone dosing, the morning dosing, the evening dosing, and the DHEA morning dosing. And then at the bottom of the calendar, we see symptom observation codes. Now, these are common symptoms that men experience when their testosterone levels are low. So I ask my patients to keep track of their symptoms. And at the end of each cycle, we should reevaluate how they're doing. So this allows for very, very accurate adjustments based on how the patient is responding to the treatment. And this is the July calendar. Now, testosterone replacement therapy has been very, very safe in my experience. Rarely, if ever, do I have patients complain about side effects. In women, if they apply too much testosterone, we may find side effects like deepening of the voice, unwanted hair growth, oily skin, development of acne. But in men, we typically don't see that, but it certainly could happen if the amount of testosterone that they use is too high. And certainly if the patient applies too much testosterone, some of that testosterone could be converted into estradiol. And if that happens, we have to either lower the dosage of the testosterone or put the patient on an aromatase inhibitor, because the enzyme aromatase is responsible for converting testosterone to estradiol. So we would use an aromatase inhibitor like arimidex if that's the problem. Now, a common concern that patients have in general with hormones is the use of bioidentical hormones, or hormones in general contribute to the development of cancer. And I don't believe that's true. And I've really never had a concern about that, because these hormones are bioidentical. I don't believe that the body would make anything that's inherently carcinogenic. And certainly, young men have high testosterone, they feel great, they look great, and there's very little cancer in young men with high testosterone levels. But here's some information, because prostate cancer is quite common. One of the standard therapies for prostate cancer is anti-androgen therapy with a drug like Lupron, which is, in my opinion, terrible, because patients feel horrible when they start on a medication like Lupron. So here's some information that says that testosterone replacement therapy for men with a history of prostate cancer does not increase recurrence rate following radical treatment or progression rate after placement on active surveillance, investigators report at the American Urological Association annual meeting. And here's the chair from Cleveland Clinic's Urological and Kidney Institute said that investigation by Dr. Morgenthaler's team adds to the existing data that testosterone replacement in men with early stage low-grade prostate cancer or those treated for cancer is safe and does not appear to increase the risk of progression. And this is something from the Indian Journal of Urology. So overall, current clinical data seem to suggest that androgen replacement is an appropriate therapeutic option for men with symptomatic hypogonadism, provided that patients continue to receive regular prostate screenings. So that's the end of my presentation so far. I have some pictures from Knowles Apothecary, so the time is yours now, Alan, and of course we'll have time to answer questions.
Thanks, Dr. Bloem. I think Dr. Bloem gave everybody a good overview of what testosterone does and doesn't do and why we need it. And I can tell you from my perspective on seeing patients, just I would say in the last 10 years, what I've noticed is younger and younger patients coming in with low testosterone levels. So before, I would say more than 10 years ago, the average patient was like in their 50s, and now we have patients in their 30s and 40s. And I guess a lot of times what they're looking at is that a lot of the food is being altered, a lot of the hormones and the meats and things that people eat and fast foods and supermarkets and things like that can definitely seem to affect your hormone levels for men and women. So it's kind of interesting to see a 35-year-old or 40-year-old coming in with their test results and they have really low T levels. So I guess the first two sort of testosterone products that came out that people are pretty familiar with would be like Androgel and Testum. When they came out, they would fly off the shelf. I mean, it was crazy. After a few years of patients being on them, and when they had some time on these products, we started to hear different complaints and different issues that patients would have. I can show you with like some syringes, like quantities of gel or cream that you have to apply. Dr. Bloem talked about we do the Wiley Protocol. We're a Wiley Protocol certified pharmacy, so we follow the protocol. We send our stuff out to be tested. We have the Wiley Protocol in place. Patients really do really well. I was talking about the commercially available products like Androgel. To give you just an idea, like 25 milligrams of Androgel so this is a 3 cc syringe. I don't know if you can see that, but that's about how much cream there is in 25 grams. And 100 grams, it's 10 cc's. So it's a fair amount of cream. I mean, these things come either in pumps or in gel packs. So you'd apply the pump of the gel pack to usually to the shoulders and to the abdomen. Most of the issues that patients have with these particular products would be you take a shower in the morning, you dry off, you put on 5 to 10 cc's of cream. To give you an idea, a teaspoon is 5 cc's, a tablespoon is 15. If you use 2 packets, it's essentially putting like a teaspoon of cream on each shoulder. So patients would put this on in the morning before they would go to work. If you wear a t-shirt or a shirt, you'd have to wait for it to dry. If you kind of covered it up too quick during the day, you'd notice that like your clothes would stick to you. Or at the end of the day, when you would take your clothes off, it would be like you're peeling your clothes off of your body. Another thing that you have to be careful about is transferring the hormones to your partner or to your children. People would have this on there if you have any small kids that you'd pick up and hold in the summer, especially if you're shirtless and you're sweaty. You pick up your child, they're pressed up against your shoulders where you're putting the medications. And there have been cases where kids haven't ended up being hospitalized, but they've had some interesting things going on with kids. And they go to the doctor and they're like, wow, it's kind of weird that your son or your daughter has this really high testosterone level. And then they would realize that they were not letting the creams absorb in well before they were coming in contact with other family members, whether it's kids or it could even be some women started to have some high testosterone levels, and it was because their partner had, they're putting this cream on and they're not letting it properly sort of absorb. The nice thing about compounded versions, the Wiley Protocol and some of the compounded creams that we use, this is a 10 cc syringe. This is a 1 cc syringe. The same dose that you'd have to get in 10 cc's would be the equivalent of 1 ml. You have to put on this much cream or this much cream. And we can make the creams more concentrated to put on less. The patients really like that. The other thing is in the commercially available products, there's a lot of alcohol and there's also it's almost like an aftershave kind of smell. So patients would complain or they would say that, I'd go to work and people would say, oh, I smell some, do you have on cologne? Well, it wasn't really the cologne. It was just there's a certain percentage of alcohol in the commercially available products, and it does give off sort of like a bit of an odor. It's not bad, but it is sort of a cologne sort of kind of smell. So static dose is when you just put on the same dose every day, daily, versus the Wiley Protocol, which tries to mimic the body's natural testosterone levels during a given time. But whether you use the static or the Wiley, whether you use the compounded version or the commercially available version, I would say 95% of men that start a testosterone replacement program will stick to it. It's the same with women when the HRT programs that Dr. Bloem designs, whether it's commercial or compounded, I would say it's about 95% of the people. Once they start, you feel better, usually in a pretty quick time. So you haven't felt like yourself in months or years. And within 1 or 2 weeks, patients will start to feel the difference. They notice their energy levels different. They notice that if they're trying to work out and they're not really getting anywhere with that, they notice that their muscle mass becomes better, less brain fog, more energy, things to that nature. As far as the compounded things that we do here at the pharmacy, like again, we're a PCAB accredited pharmacy. We send our products out to be tested. We only buy our chemicals from FDA regulated companies that test these products, these raw chemicals before we purchase them. So everything that we get in has a certificate of analysis, which tells us how pure it is. If a chemical fails an inspection, then it doesn't even make it to the point where it gets to a pharmacy where we then compound with it. We do send our products out quarterly to be tested, so we know the process that we're using is correct, and that the pharmacists and the technicians here, everybody goes through a training process, so we know that we're giving out a consistent product at all times. You can go online and you can find, I've had patients say, hey, I went online and I found a compounding pharmacy out in Ohio that their prices are cheaper and this or that. Pharmacy is pretty regulated. The USP guidelines for compounding are there for a reason, and not everybody adheres as strictly to these guidelines. Some of the other things are, you're usually getting a commercially available product, and it may have, once it leaves the pharmacy, it's the law that we give it a year expiration date. So even if you look on the box and the expiration date might say it's good for 2 years, once it leaves the pharmacy, everything gets a year from when it's a compounded version of the products have shorter expiration dates. And those expiration dates are based on studies, whether it's a cream base or a gel base or an alcohol base. Certain bases will keep things stable for longer times. So for the most part, compounded versions of testosterone have usually like a minimum of a 30-day to a maximum of 6 months. But essentially, we make these products up sort of fresh each time we get a prescription, or we make up small batches. So you're always going to use your product within the time frame that the medication is good for. We have some people say, I want to get a year's supply up ahead. We don't really recommend that. We can, if the product has a 1 month or 6 month expiration, if you want to get, we kind of guide you into, the different bases for different people for different reasons. So there's a proprietary base put out by a company called PCCA. It's called Atrevis. Has sort of a penetration enhancement properties. So when you put on a regular cream base, the testosterone will sit on the skin, and it does absorb a usual rate. Some of the creams that have penetration enhancements, you'll get a better penetration, or you may get more of a sustained release penetration through the skin. So that helps with a better steady state of the product. There's different ways we dispense it. Sometimes we dispense it in a syringe. There's also something called a top click. So this holds about 30 grams of cream, and it's a little bit hard to see on this, but there's a little hole in the top. And every time you do a twist, you can see that cream came out. So this will dispense like 0.25 mLs of cream. We have some that dispense 1 ml. We have some that will dispense 0.25. So the thing you have to sort of balance with the testosterone is, it's not great to have 5 to 10 grams of cream to spread across your shoulders, because it is a lot to absorb, and that means you need a longer amount of time before you get dressed and you come in contact with other people. And so you also don't want to have just a teeny tiny amount, because you do want to be able to spread it. So if you only put on, 0.1 ml of cream, some of that's going to get absorbed in your finger, so you do want to have a little bit of cream to move around. But with the compounded versions, we have, people are applying anywhere between maybe 1 to 2 grams, 1 to 2 mLs, depending on what it is. And with the penetration enhancers, patients really get much better serum testosterone levels. So we do have patients that do, get tested regularly. We have patients that have been on high doses of Testum and Androgel. And again, it works great for some people, but sometimes patients are just not getting the blood levels that the doctors want and that the patients are looking for. And when they do change to some of the compounded versions, I really have had doctors call me up and say, what dose, what are the patient getting? Because for the last, 3 to 6 months, our levels have been, not very high. I haven't been very happy with what it is. And I don't know whether it's the patients aren't being compliant, and the patients are, no, I put it on every day. But when you change to the compounded version, which is a lot more concentrated and have these penetration enhancing bases, their levels have gone up to the point where sometimes they actually have to be cut back after 3 to 6 months. One of the really good things about Dr. Bloem is that he's very in tune with the patients. He's very hands-on. He does order your blood levels to be tested, and that's not to try to make more money for himself or more money for the testing places. It's really important to know what your levels are, and if it's too low, to increase it, and if it's too high, to decrease it. We have unfortunately, there's a lot of doctors out there that write a prescription and they don't see the patients for a year, sometimes more, and the patients are not being tested on a regular basis. And if you don't do that, you're really doing yourself a disservice, because maybe you're under where you should be, and you'd feel better if you were adjusted. And if you're too high, then you need to be tweaked up. So a lot of the creams that Dr. Bloem writes and other physicians that use compounding services, you're really getting something that's specifically made, for you. So your level may be different than your friends, or even within families. We have where, the father and the sons are all getting the same concentrations, but have to use different varying amounts to get the same result. So, everything is very specific to each person. So not everybody needs the same dose. And that's where compounding and, having a doctor that's going to be, follow your case, pretty tightly is, what you really need. Bioidentical hormones versus commercial non-bioidentical. If you think of it as like a puzzle piece, a bioidentical hormone is going to fit in that puzzle, better. And the better it fits in your body, the less issues you're going to have with side effects and effects that you don't want to have. So bioidentical hormones will, you get better levels, you get less side effects, and you got to have a better experience for it. That's sort of what I have in a nutshell. I don't want to keep you guys here, all night, but if anyone has any questions or Dr. Bloem wants to ask anything or add, please do. But I want to thank everybody for, coming in and doing that.
Oh, that's great, Alan. So we actually do have some questions here, some very good questions. So let me address those. So first question is here, can you comment on Clomid versus testosterone replacement? Yeah, actually, I learned about Clomid. Clomid or clomiphene is a fertility drug. It's used in women, but it can also be used for men off-label to help stimulate the body's own production of testosterone. So yeah, so definitely clomiphene. I learned about it from one of my patients and had some very good results with that, and it's something that I might consider for some of my patients. Now, one concern, and this is actually another question, because from the same person. Does testosterone replacement therapy cause your natural production to decline? Just bring to mind one of the first slides that I showed you. So there's multiple control systems within the body. We know that the hypothalamus has some releasing hormones that affect the pituitary gland. The pituitary gland has stimulating hormones that affect the testicles. And so we know also that there's a negative feedback control mechanism that makes sure that the hormone levels stay within a certain range. So if the testosterone levels get too high, that will send a signal to the pituitary gland to lower the secretion of luteinizing hormone, which normally stimulates testosterone production. So the concern is, and this applies to a lot of different types of hormone therapies, if I prescribe or if I take testosterone replacement therapy, does that reduce my own natural production? And I think to some extent that's probably true, but for most patients that I treat, it's frankly irrelevant because their body's own production is already very, very low, and just applying some physiological amount of hormone, and of course we guide the treatment by doing blood testing and by following the patient's symptoms, the response to treatment. I have not found that to be a significant concern. Now we see that that's more of a problem in athletes that abuse the illegal anabolic steroids, where they use unusual amounts, you'd say super physiological amounts of testosterone androgens to build big muscles. Those patients can certainly experience liver damage. They can experience a shrinkage of their testicles. Basically, side effects from using too much testosterone, causing a negative feedback, too much negative feedback to the pituitary gland, result in shrinkage of the testicles. And I have not found that to be an issue in my patients. Now, with regard to lab testing, if somebody's stable, lab testing doesn't need to be done more often than once a year. But if we're trying to work with the patient to optimize the testosterone levels, and either they find that they're not seeing the results that they're looking for, the libido is still low, and erectile function is still poor, I think it's very appropriate to do some lab testing then to find out what the testosterone levels are, what the estradiol levels are. Again, if the estradiol levels are too high, we want to lower the testosterone, maybe use some aromatase to block aromatase. And so it depends on the patient how often we should have the lab work done. So it could be as frequently as every 1 to 2 or 3 months, or as infrequently as once a year. Another question here about saliva testing versus serum testing. Of course, there's different schools of thought on this. There's some doctors that will do saliva testing exclusively. I've done serum testing mostly. I know you can also do 24-hour urine testing for hormones. I've done that in the past. If somebody, really wants to know, we can certainly order that. There's specialty labs that can provide tests like that. But for the most part, I do serum levels, and clinically very useful and helpful. Another question, what percentage of your patients are using creams versus injections? I would say maybe 2/3 will use creams and about 1/3 using injections. And another question, how do you determine what route of administration? I leave it up to the patient. Some patients don't want to apply the creams twice a day or once a day. They would rather do an injection of testosterone cypionate once a week or every 5 days. And of course, there's some other patients that are too afraid to give themselves an injection, so they go with the cream. So I just leave it up to the patient, and whatever the patient is comfortable with. And I have very satisfied patients who do the injections, and likewise I have very satisfied patients who do the transdermal application. Any comments, Alan?
As far as that goes, I would say the same thing. It's probably about 75% topical and about 25% injection. One of the other things that may or may not be a problem for some patients, not everybody's insurance will cover the testosterone. It's pretty expensive commercially, so out-of-pocket cost can be anywhere between $200 to $400 a month for commercial products. Compounded products, for the most part, I would say are under $100 a month out of pocket. So sometimes that's a consideration. So sometimes we have some patients that their copays can be between $100 and $300 a month. I mean, some people have, their insurance will pay for all of it. Some of them don't. And then some people don't have insurance and pay out of pocket. And when you pay out of pocket, the commercial products, like I said, between $200 and $400, depending if it's brand or generic and, what dose it's going to be. So that's something to think about a little bit. One of the other things that patients don't always think about when they start applying things topically, that your skin is an organ. So when you want to make sure that you apply creams, like when your skin is clean and not, you want to be showered and dried and not wet, because that can inhibit absorption. And we also have had issues where people put on skin lotions or sunscreen and things like that. So you always want to put your hormones on, topically first, and, wait at least, 20 to 30 minutes before you use anything else on top of that, because a lot of people do use, you have dry skin in the winter and things like that. So we've had patients that have done really well and all of a sudden, start to have issues, or, their levels dip. And then when we sort of interview them and talk to them, we find out they're like, oh yeah, well, I take a shower and I do use baby oil, or I use I use some sort of topical skin cream, and I put that on when I get out of the shower, and then I put my hormones on top of that. So you want to make sure that, you're giving yourself your skin that is, dry and sort of free of oils and sweat when you do apply. That's a definite thing that, people don't always, take into consideration. It's also like rotating sites, because, when you apply, the hormones to one place all the time, it can affect, your receptors can kind of get used to it, and you may not get the same absorption in the same place. So that's why, Dr. Bloem said, and we always tell our patients to, go to one side, go to the other side, rotate your sites, and don't always, apply hormones to the same area all the time.
Jorge, did you have a question?
Yeah, I have a question. Is there any age limit? I'm 71. Can I still use that? How effective is it in my age, or is there any adverse effect if I have a high blood pressure, but I'm using medicine for high blood pressure, and it's under control? Is there any comment on that, if it's okay to use?
Very good question. Yeah, so there's really no age limit. And, with regard to, other medications that you may be taking, I'm not aware of any interactions when the testosterone is dosed judiciously. When levels are checked, when the patient's response to treatment is checked. I would say the reverse is true. If you're in your 70s and your testosterone are low, what does it mean? You're most likely you have osteopenia or maybe osteoporosis, because your bones need testosterone. Cardiovascular function is not optimal, because obviously the heart is a muscle and needs testosterone. So you could only benefit from using testosterone replacement therapy, regardless of age. I would say the same is true for younger patients, the other end of the spectrum. In the younger patients, patients, it would be better to start something like clomiphene to stimulate the body's own production of testosterone instead of using testosterone, which has the potential of inhibiting the body's own ability to produce testosterone.
What is the normal level? The normal level of testosterone, the normal to optimal level to have?
Normal levels in young men are in the 900 to 1100 range. Now, if you come to me and your levels are, say, 100, well, we want to bring it up. It doesn't necessarily mean we have to bring it up to 1,000, but if it comes up to 600 or 700 and you feel good, that's where we'll keep your dosing.
Okay, if you take the compound, how long it takes to get to that level?
The hormones get absorbed pretty quickly, and you'll know if you forget to take a dose, you'll know that you're
Really?
worse. So that's why most of my patients will apply the testosterone twice a day, and especially with the rhythmic dosing protocol. Now, some patients tell me, I really feel worse when I'm applying less versus when I'm in that time of the month where I apply higher dosages. And some of my patients ask me to modify the curve so they take more overall. So you can actually know pretty quickly that it's working. I mean, it's kind of like, when you're thirsty, you drink a glass of water and you feel better right away. And it can be like that with hormones as well.
So let's say I started tomorrow, and after that, do I need to take a blood test? Or how do you check?
I wouldn't do the blood testing that soon. No, I would, depending on what kind of protocol you use, whether it's injection or transdermal, I would wait, at least a month. Now, if after a month you didn't feel better and you're still at a relatively low dosage level, then I would increase the dose a little bit more before doing the blood testing, because most likely, if you don't feel good, then the levels are still going to be low. Maybe you went from 100 to 250.
Mm-hmm.
And so, yeah, it's better to wait to do the blood testing until you start to feel better, at least. But we can certainly do the blood testing at any time if you want to know.
I'm afraid if you reach the level, the desired level, you need to keep it on taking, because otherwise it will drop, right? To maintain it.
Yeah, as soon as you stop taking it, it will drop again.
So it never gets auto replaced. It has to be maintained by taking this cream or injection.
Yeah, and of course, most patients tell me they would do anything to continue taking these hormones because they're so life-changing.
So you have available this cream?
So I send a prescription to the pharmacy, and then Alan can compound it, and it usually takes at least a day or two for them to get it ready, because everything gets compounded for a specific patient.
Okay, great. So we need to talk then.
Okay, all right.
Thank you.
I want to thank everybody for joining us, and thank you, Alan, for joining.
Thanks for having me.
Thank you.
Yeah. So again, just to summarize some key points, hormone balance can occur at any age, and it's true. I've seen men in their late 20s, 30s with these issues. And if somebody has anxiety, depression, and they're a young man, it wouldn't hurt to check testosterone or DHEA levels. So it's not only for symptom relief; it helps protect bones, brain, heart, sexual function. Doing a detailed medical history, a laboratory testing are both very important. We will personalize the treatments for you, and there's certainly affordable options. There's something for everybody. And with regard to my office, I'm available for telemedicine appointments for patients here in Maryland. And it's just been a very fun treatment for me to offer to my patients for more than a decade now. I want to thank Alan, because I guess when Alan and I first met, I was very new with this, and it's great to have a compounding pharmacist that you can talk to and who can advise you on treatments like this.
I just want to again, thank everybody, and if anybody has any questions, please, contact Dr. Bloem or contact myself at Knowles Apothecary in Kensington. People asked about age. I mean, I can right off the top of my head, we have patients that from 19 to about 92 years old that supplement with testosterone and some other hormones. And I can tell you, hormone therapy is, people will refill their hormones on a more regular basis than they do their blood pressure medicine or anything else. Like they are like on the day, they're very, once you start to feel better, you really do notice the difference. Like, some patients is within a couple of days, definitely within the first week. Patients really will say, they'll call up and go, I don't know if it's in my head or not, but I just feel like I have so much more energy. I feel like I used to feel, is it real, or am I imagining it? So, hormone replacement therapy has really done wonders for, men and women, and, patients that really benefit from it. Again, it's something that you will, notice pretty quickly based on the patients that, that I have. And, we have hundreds of patients.
All right. Well, thanks again, everybody. I plan to host more webinars, and I'd love for Alan to join me again in the future, and we'll schedule something for next month.
That's good.
Okay. Good evening, everybody.
Good evening.
Stay safe.